So from the payer perspective, these expensive orals, pills that are $1,000 a day, become a huge issue. Medication therapy management, adherence, compliance, persistence, how it's impacting your overall cost, and then tracking it when those orals are, through contractual arrangements and your ASO clients are coming from all these different sources of distribution. How do you manage this? Or how are you starting to change the thinking about how you're going to manage this?
Well, one of the things that all payers are doing is they're splitting out, quote, specialty pharmacy. And we were working with vendors who are negotiating better deals. But what happens with that is a single oncologist may not know what the channel is for this. And so you have a drug that's $1,000 here with one, and that's maybe patient out-of-pocket cost, but instead they take the prescription and they take it to their Walgreens. And Walgreens can get the drug in 48 hours and still do it, but there, instead of being $1,000, it may be $1,400. And so it puts a lot on both the practice and it's incumbent on the patient. The payment systems on these get really complex and they're really variable in terms of cost. So we really are shifting the burden. We're trying to simplify that as much as we can, especially when we have ACOs and whatever. But that's really a burden. Another thing that we see too is these drugs, typically if they get them through mail order pharmacy, they get a 30-day supply. And a huge number of these are wasted because after 3 days, the patient isn't tolerating that $1,000 Apilda, and he's got that vial worth $27,000 sitting in his medicine cabinet next to a shaving cream. And these get to be, having to manage some of this.
So you're doing a split fill?
We're trying to do split fills, 7-day initial fills, trying to do some of those, but not all the PBMs are consistent with that. So there really is an issue because a single month supply of these drugs is so expensive. If the drug isn't tolerated, or even if is taking the drug over the sink and drops it goes down the drain. If it was your lisinopril for $4 a month, big deal. But this is huge. I mean, there's a lot of wastage in handling the drugs.
And this isn't unique to oncology. I mean, it's going to spill over into
rheumatology, into many directed therapies, and all the new therapies. Formerly, the oral quote onc drugs were largely hormonal manipulation. All these targeted therapies now, which are incredibly expensive, and they're going to proliferate. It's going to be I think it's a real management issue for all of us.
So let's be clear. This has become an extraordinarily emotional argument in the oncology space. Let's talk about what the system is and why it is, and what we're trying to fix. What are we actually trying to fix? So what's the system? The system is PBMs have developed specialty pharmacy infrastructure to handle these very complicated drugs, to handle prior auth and management of multiple different benefits designs with co-insurance, co-payment, all the other stuff. But PBMs existed because they were a very efficient way to handle a high-volume business, and they were a pretty efficient way to manage classes. So you could tier, you could select, and negotiate and contract around selection, thereby driving down cost of care. And they do that very, very well. But specialty drugs don't really fit by those rules. Because of this tight association between specialty pharmacies and the PBMs, and the relationships that payers have with PBMs, fracturing that relationship has potential consequences, and it's not something that will be done, oh, you're going to do a better job, we'll just give it to you. It's complicated. It's a complicated relationship.
Why? Why?
Why?
Why can't you?
Because these are big, so it's like negotiating with a hospital.
But why can't you independently contract the specialty drugs with a separate vendor if the PBMs aren't?
Oh, you could, but the PBMs will push back, and what's going to happen is it's going to be like negotiating with.
So if I understand, you've got a historical system that was based on leveraging volume throughput, and you've got a new system that's highly precision and targeted, and that needs white glove, per patient redress. So
let me
you've got two systems that have to work differently.
What problem?